Good evening, and thank you for joining us for this webinar, Treatment Options for BPH Enlarged Prostate, presented by Dr. Anthony Woodruff. Dr. Woodruff earned his medical degree from the University of Arkansas for Medical Sciences and completed both his urological residency and surgical internship at Ochsner Medical Center at Louisiana State University in New Orleans, Louisiana. Dr. Woodruff completed a fellowship in minimally invasive urologic oncology at Virginia Mason Medical Center in Seattle, Washington, and served as the director of robotic surgery at Northwest Medical Center in Fayetteville, Arkansas. He joined Arizona Urology Specialists in 2009, and he practices out of our Scottsdale office. He is board certified by the American Board of Urology. He specializes in minimally invasive urologic surgery, including the UroLift procedure for BPH Enlarged Prostate. Thank you, Dr. Woodruff, and welcome.
Thank you, Jennifer. That's me on the front there. We'll get started with the talk about enlarged prostate. We're going to have some objectives to go through today, kind of an agenda, if you will, to what we're going to try to accomplish. And by the end of this lecture, hopefully that you guys will understand better the importance of your prostate, what BPH is, how we diagnose it, what your treatment options are. And then I want everybody to make sure they understand the UroLift system. It's a very simplistic procedure. And I think once we get done with this, hopefully everybody will understand exactly how it works. The prostate is a walnut-sized gland at the base of the bladder. It's illustrated here in a sagittal section as if we make a slice through the middle of the body and you're looking forward at it. It surrounds the urethra. So the urine has to go through the prostate to get out of the body through the urethra. And it also, the one thing the prostate does that men need is it makes a protein in the ejaculate that makes a sperm able to fertilize an egg. So once you're done having kids, your prostate doesn't have much of a function. And in fact, it just kind of gets in the way as men get older over time, as you can see with this chart. When you're a little boy, your prostate's very small. Then once you go through puberty and your body starts making testosterone and DTH, which is dihydroxytestosterone, which is a degenerative testosterone. And that's what makes your prostate kind of tend to grow, and it can grow through all phases of your life. Common prostate conditions that a lot of men have had, a lot of have heard of: prostatitis, that's inflammation or infection of the prostate. Prostate cancer, which is the most common solid organ malignancy in American men, typically grows slow and it typically presents late in life. And then you have enlarged prostate, which is a little bit of a misleading definition, but I'm going to get to that in just a few more slides. This slide just basically shows that as you get older, the number of men who have problems with their prostate that give them problems, and we're talking about mainly just voiding, that your prostate tends to change throughout time and affect the way that you urinate. So what is BPH? Well, BPH is benign prostatic hypertrophy or hyperplasia, and it's really kind of misleading because it's not necessarily growth as much as it is the channel which the urine goes through that's restricted by the kissing lobes of the prostate, which we're going to illustrate in a moment. It has nothing to do with cancer. It's not a predictor of cancer. It doesn't become cancer. PSA can rise with both BPH, prostate cancer, and other conditions as well, such as prostatitis. And so PSA can't tell you necessarily what the issue is. We base that off some other things. If you have a prostate, if you look at these images, I wish I had a laser pointer, but the one on our left is basically a normal prostate with the channel open. And the one on the right, you can see that the prostate is pinching the middle of the channel. What that does is it makes the urine flow dynamic such that it restricts it and it won't let the urine come through. And that's what we call BPH, even though you can have a really big prostate with an open channel or a really small prostate with a tight channel, and the result ends up being the same whether it's big or small. This is a good illustration of what happens when the channel gets tight. The bladder is surrounded by a muscle called the detrusor muscle, and to void, you have to have two things. You have to have an open channel and a muscle that squeezes. And so as the muscle has to squeeze harder and harder over time, this bladder muscle gets hypertrophied, gets larger, and then eventually it can actually quit working. And so this is kind of disease progression. This on your left would be kind of a normal prostate in a younger man. And then the central zone of the prostate is usually what becomes more glandular as a person gets older. You can see kind of a normal opening on the left below, and then it's getting up, the lobes are getting closer. And then on the far right, our lobes that are all the way kissing and coapted against one another, which keeps people's urine from coming out. And it results in lots of different things like frequent urination, urgent urination, weak stream. Sometimes it results in painful or difficult urination. Usually that's not a huge symptom for most people, but it can be getting up at night, having to plan out your day and plan out what you do. Or go to the airport, you make sure you go to the bathroom, and you get on a plane, you got to get to the bathroom, and you're kind of designing your life around your urinary problems. And that can become a real problem for people. So how do we diagnose it? A big part of this is medical history. When a patient comes in and we talk to them, we ask them several key questions. Usually that really gives us a lot of insight into exactly what their symptoms are. We usually have them fill out an International Prostate Symptom Score, an IPSS. That's a validated questionnaire that kind of helps us understand exactly what symptoms you're having and which ones are bothering you the most. Oftentimes we do a bladder scan that shows how much urine is left residual for the bladder not emptying, digital rectal exam to get texture and approximate size, although you can't definitely tell size by finger test. And then ultimately, how much is this bothering you? Usually by the time men get to the doctor, they're not going to take time out of their day and interrupt their life to go to the doctor if they're not pretty bothered by this by the time they get to us. Other studies that we often do to kind of better understand what your options are would be a uroflow test, which measures the flow of your urine, a urocuff test, which does the same thing by a different design, pressure flow studies, which are when you use catheters and try to tell exactly how much pressure the bladder is exerting. Another word for that is urodynamics. Oftentimes we do a transrectal ultrasound of the prostate, and that's to look at the architecture and the anatomy from kind of the outside. Cystoscopy is where we put a scope in through the urethra and we look at the prostate from the inside, kind of like those pictures from a couple slides ago I was showing you. So this is about the IPSS score, and it's a urologist friend. Every patient who I have come in, male or female, fills one of these out, and it goes over these questions. It says, how often in the last 3 months have you had, incomplete bladder emptying? And you circle 1 to 5. Frequency 1 to 5, they're graded. So this is a breakdown. If you have mild IPSS symptoms, and it's 0 to 7, 8 to 19 is moderate bother, and then 20 to 35 is severe bother. And then you have the quality of life score, which 0 is delighted and 6 is terrible quality of life. That's kind of a really quick summary of kind of how we work this up. So just to kind of summarize, history and physical, some lab work sometimes, and some imaging, and maybe looking in the bladder, looking through the prostate. And then that's when we come to treatment options. So there's a lot of treatment options for this because it's been around since the beginning of time, and technology has advanced so much in the last 10 or 15 years that things have kind of evolved forever and ever back to the earliest time. A lot of guys had to live with this just for their whole lives. And then around the turn of the 20th century in 1904, a guy named Hugh Hampton Young did the first transurethral resection of the prostate through the urethra with the resectoscope. And so that is still available, although the technology is much, much better than it was in 1904, and we still perform those. But now there are other things that have also come into the field which are helpful. So things like medications, alpha blockers like Flomax is a very popular one, Proscar, Avodart, these medicines kind of shrink the prostate. And then there are other remedies like saw palmetto, which has basically been proven not to really work very well, but that is something a lot of people have used in the past. And then you have more invasive therapies like laser prostatectomy, like I said, going in and doing a Roto-Rooter, and then you have UroLift. This is kind of a spectrum of less invasive to more invasive. Obviously, the less invasive has some advantages. If you don't have surgery, then you can't have complications from surgery. Not doing anything doesn't cost money because you're not on medicine. And then disadvantages of doing something more invasive could require lifestyle change. You may or may not have a good response. And then you have a risk that things worsen. Over time, medication actually ends up being more expensive than surgery, which is why Medicare and insurances actually kind of want us to do surgery if we can, if people are a good candidate, because not only does it fix the problem, but it keeps people from being on long-term, lifelong medicine. As I told you about, there's Flomax, Avodart. Cialis is an erection medication that in some studies have shown can kind of relax the urinary channel and help men urinate a little bit better. The medications don't have a lot of really long-term side effects. They're pretty safe. They do have downsides. Flomax and alpha blockers can make men dizzy. It can give you retrograde ejaculation. So when you have an orgasm, nothing comes out of the penis, and a lot of guys don't like that. Avodart and finasteride can cause you to have some decreased sex function, decreased sex drive, erectile dysfunction. And so they have some side effects. Herbal remedies, honestly, they don't really work in studies that have been done. So I usually don't encourage them. They don't hurt anything, so they're okay to take if you want to try them. Back to the UroLift system again, it is the most minimally invasive of all the minimally invasive surgeries that we have right now on the market. One big advantage of UroLift for a lot of men is we can do it in the office, and it just takes a couple minutes, and most guys tolerate that really well. Some people who are kind of shaky about that kind of stuff, we take them and put them to sleep at a surgery center. But whether you do it in the office or at a surgery center, it's just a couple minutes worth of treatment, of surgery. You go home the same day. It should preserve sexual function. I haven't had any patients to date who've had problems with ED that was relatable to UroLift or retrograde ejaculation or any of those things so far in my treatment practice. Usually with the UroLift, it's pretty immediate recovery of urination. It's not for everyone, and I'll get into that detail in a little bit. But with some of the other therapies like TURP and laser, there's a much longer protracted recovery time that can last up to even 6 months. And so UroLift is a little bit more immediate. Disadvantages are the category here that says you may experience some discomfort. There'll probably be blood in your urine. There'll probably be increased urgency of urination. Most of these symptoms are gone within a week. Most people who have those symptoms, it lasts for 2 to 3 days. And then usually you can continue to improve there for a few weeks. And I'm going to talk about that again. Heat-based therapies like tuna and microwave and TUMT, radio frequency, not resume, but the rest of those have kind of fallen by the wayside. They were popular for a while. And then after studies were done longitudinally, the 5-year success rate of the tuna and the TUMT were really found to not be very beneficial. Resume is newer, a little newer than UroLift. It's been around for, I guess, a couple, 3 years, and it uses steam to cavitate the prostate. And it's just a different approach. And in my experience, the guys that are better candidates for Resume are the guys with the really big prostates who maybe the UroLift system is not really typically developed specifically with them in mind. The heat therapies do tend to have a lot more irritative voiding symptoms like frequency, urgency, burning, and those can last 3 to 6 months. It's usually about 6 weeks that they last, as opposed to UroLift 2. That's really not something you usually see. And then major surgery, the definition of major surgery is when it's happening to me, is what I always tell my patients. So anytime you have going in through the penis, putting you to sleep, and we spend an hour, hour and a half reaming out the prostate, getting out tissue, that has some side effects. There's a low retreatment rate. They tend to be successful. They tend to be durable and last for a long time. The disadvantages is there's a lot more risk to doing something that much more invasive. You usually have a catheter from anywhere from a day to 2 weeks. It can cause some erectile dysfunction. It can cause, this number says 40 to 65% lose ejaculation. That number is more like 95 to 100%. There's not a 3% risk of incontinence. I would say that's more like less than 1%. There's about a 5% risk of strictures. Those are things that happen with this, which are just a little bit more involved in the UroLift system. Then to kind of get into the granularly into the UroLift system, there's a video I'm going to show you in a minute that I think is very explanatory, but this is kind of a frame by frame. And on the far left, you have the enlarged prostate at rest. And then there's the UroLift system being placed through the prostate. Step 2 over here, that is a deployment of the implant. And that implant attaches onto the outside layer of the prostate and then basically just squeezes the prostate open, because the prostate is spongy. And the outside capsule that you're seeing on the edge there, that's a leathery surface that will hold that suture, and then it just squeezes open. So you squeeze it open on that side, you squeeze it open on this side, and you're left with the big open middle like that is illustrated in step 3 there. This is a picture people always want to see, the implant, and I have a little block in my clinic that has an actual normal size implant. This is obviously blown up, and you can see to scale that it's smaller than a quarter, and you have the little nitinol capsular tab, which goes on the outside as an anchor, and then the inside little staple that does the pulling, and the suture stays the same length. So when you put it out, it pushes over. Now, this is a video that I think is really good.
The UroLift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia.
This is like going through the urethra BPH. And looking at the prostate.
The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructed prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
I like that video a lot because it's a very good illustration of exactly what I do. The procedure that you just saw it go through, that's about how long it takes me to perform the whole procedure. And obviously, we usually either put in 4 or 6. Those are the most common numbers. And if I had to put 2 more in, then it would extend it by that much more time. But that's a great illustration. Hopefully that's understandable to everyone. And this is another picture that they kind of just showed you already. On your left is the pre, and you can see the blocking portions of the prostate. And then on the right, that's looking all the way through the end of the prostate, all the way through into the bladder. So it's a big tunnel that's wide open. And you can imagine that urine would go through there very well. So if the bladder is able to squeeze at all and you can get an opening like that, I told you at the very beginning, 2 things: open channel, squeezing bladder. That will result in a beautiful urination for that gentleman right there. And that's usually about exactly how they look. So this slide was not made by me. I disagree with a few nuances here. I would say if you're going to have symptom improvement, which most people can count on, I would say you reliably start having that by 2 to 3 weeks, almost across the board. I've had many people who didn't feel like they got all the way better for 5 or 6 months. That's an exception. Usually you're about where you're going to be at 3 months. I've had several people who have immediate relief, like the day of. I tell people not to expect that. If you have the UroLift and you come into the procedure with no catheter, then I'm probably not going to put a catheter in. We're going to send you home without one. I tell people to be prepared to burn like razor blades for 2 or 3 days and drink a lot of water, stay away from dietary irritants, and that usually goes away. I've seen it one time last 7 days for one gentleman. But like I said, when you do other transurethral prostate procedures, those symptoms can last up to 3 to 6 months. And so it's a big improvement on that. And you can see from the illustration, one of the reasons I feel like people don't have as much irritation is it's just so straightforward. You go in, you place an implant, you place an implant, you place an implant, you place an implant, and the scope comes out and you're done. As opposed to some of the more advanced, more involved, more invasive procedures, the scope's going in and out, I mean, multiple times because it has to. And that just causes a whole lot more of irritation and irritated voiding symptoms. I don't give anybody pain medicines for this just because simply they don't need them. It's really not a very painful procedure. I tell people to take Tylenol, Advil, or Aleve, and that's more than enough to take care of any discomfort that they have. Afterwards, I tell people you can absolutely count on having blood in your urine. If you don't, that's fine, but you almost certainly will. I have never seen anybody have problems from a UroLift more than a few days really out from it. There was a study published very recently, or pretty recently, that showed durability of this out to 5 years to be about 87%. So in other words, if you got 100 people that you do a UroLift on, you would expect only about 13 of those people at 5 years to have needed another procedure. And so that's a really, really good number. If you look at all these other modalities that have come and gone, like tuna and microwave and holmium laser, those things have a very high repeat operation rate, up to like 80% in some of those procedures. But UroLift has shown to be durable, which is a big deal because it's just not something that we have in this treatment space until now. As far as insurance and coverage, it's covered by everybody. Medicare does everything they can to save money. Medicare covers this kind of stuff because, like I said earlier, it fixes your problem. It gets the majority of men off of their medication. It gets the majority of men to not have to be at the doctor as much. And so it ends up saving Medicare and private insurance. It saves them a lot of money. So they're a big proponent of it. There are a few things, some hurdles we have to jump. Sometimes for some insurance plans, we have to give you a trial of Flomax and make sure that, and do that first. And that's how it is with a lot of the procedures we do. But our office takes care of all that stuff. I've never had to have a patient get involved that I can remember. I'm available. I see patients every day and talk about this every day. We can do telehealth now. Sometimes we do phone calls. I find phone calls to be very impersonal. And I like to be able to see people, even if it's on a screen, and I can really kind of read their nonverbal. And I can tell if I'm saying stuff and it's getting picked up and they're getting it, or if they're not getting it, or if I'm not making sense, I can rephrase it a different way. So I much prefer in person to a telephone. If you're going to see me or another urologist about this, it really helps for you to, in preparation for your meeting, to think about exactly what it is you're bothered by and get to the point where you can articulate what you want them to hear. Generally, we're pretty good about asking the questions that we need to ask. So it's not like a test. You're not the one that's being put to work. It's us. But if you think about it and you're prepared to articulate it, it does help your doctor get to the point a little more quickly. Thank you guys so much for all attending. I hope that it was insightful. I hope that it was informational. Make sure your urologist talks to you about this because it's really changed my practice. I think it's changed the lives of a lot of men. I had 3 guys today come in. They were almost crying. They were so happy from their UroLift of last month or 2 months ago. They're some of my happiest patients. And we all go into medicine and become surgeons because we want to fix problems and because we want to help people. And UroLift really fits in that slot. And I think that it's something that men should strongly consider if they're having those problems. Obviously, you have to be a candidate for it. But I just think it's really a great thing. And it's done a lot of good things for a lot of American men. And I would encourage you to talk about it with your urologist. I really appreciate everybody's time. Reach out to me or reach out to my office or reach out to your urologist's office if you want to talk more about it.
Dr. Woodruff is available for in-person appointments at our 92nd Street office in Scottsdale or by telehealth. For more information or to make an appointment, please visit us at ArizonaUrologySpecialists.com, where self-appointment scheduling is now available. Thank you very much and have a great evening.